Hello, and welcome to BasicstoBrilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the Southwest Deanery.
And my name is Dr. Syed Haider Jaffrey, Haematology SHO and aspiring haematologist.
And let's get started on today's topic.
From basics
to brilliance. Hi Haider, how are you?
I'm good, Harry. How are you?
Yeah, good, thank you. So today we're going to cover one of the other myeloproliferative neoplasms, this time ET, or essential thrombocytosis. So that's going to be the topic of discussion today.
Mm-hmm.
So why don't we start with a case? So here is a case, classic on-call query. You're referred a patient who is 60 years old and is a male and has been referred to the new patient clinic with a platelet count of 700, which has been raised over a few months. And the patient has recently had an NSTEMI, so an MI. How would you approach this patient, Haider, in terms of, firstly, just thinking about your differential diagnosis? Do you have any thought process you'd like to share with us?
Yeah, so a platelet count of 700, quite spicy. And the way that we've discussed previously as well to classify these things is I would go with primary and secondary at the very least.
Yeah.
And you did say that it's been raised for quite some time, and I would definitely ask that in the first instance.
Yeah.
Whether if it's a one-off result or if it's been increasing over at least 3 months.
Definitely.
And elevated for over 3 months.
Yeah, brilliant. Okay. And what do you mean by primary versus secondary?
Primary as in, well, ideally I'd start with describing secondary as being reactive to either infection or reactive to cancers.
Yeah.
I know that Lego C, one of my friends in GP was talking about Lego C cancers that are lung, endometrial, esophageal, gastric, and colorectal, not in that order exactly, that are associated
Okay,
with
so that's
a
an acronym.
high.
Lego C.
Yeah, Lego-C.
I've never heard of that before, but okay, that's good.
Yeah, so they're telling GPs to look out for these for elevated platelet counts for over a few months. I think I'm not exactly sure how long, but platelet counts above 400, 500 that are staying that way are indicators for those cancers.
Yeah.
So that's what I would look for in secondary, and then for primary, I would definitely, I mean, in this context, think of ET, and we discussed PRV previously as well, and some MPNs.
Okay, yeah, good. Exactly. So I think that's a really good place to start, and that's how I would think about a raised platelet count as well, remembering the fact that most of the time a raised platelet count is not going to be a primary thing. It's not going to be a primary hematological problem. It's going to be secondary to something else, and usually that secondary to something else is something that causes the body stress. And essentially anything that causes the body stress can lead to a secondary thrombocytosis. So in particular, infection, also inflammation, which includes things like tissue damage. So actually you can have a raised platelet count after a myocardial infarction due to it being reactive to the tissue damage. Severe exercise or post-operative, you'll have a raised platelet count. Another big one not to forget is iron deficiency and bleeding. And I don't know if this is actually the reason, but I like to think about that in terms of if you've got a patient that's bleeding, then actually raising your platelet count is a useful response of the bone marrow to try and plug the hole. So iron deficiency and bleeding causes raised platelets. Hemolysis can cause raised platelet count. And then malignancy, as you said, so solid cancers like renal cell carcinoma or your Lego C thing, which I've not heard of before, but that's quite a good way to remember. But any malignancy. And then things like, remember your spleen. So I've classically been phoned about patients with a very high platelet count, and actually they've had a splenectomy in the past. or hyposplenism as well, from, let's say, maybe in sickle cell, something like that. And then there are certain medications that can raise your platelet count, so steroids and adrenaline, and some cytokine administration, like if they're on a TPO agonist, for example. For example, maybe they had ITP and you put them on L-thrombopag. And then rebound after myelosuppressive chemotherapy. Sometimes you can just get a rebound platelet count that rises above normal before it comes back down. So with all secondary thrombocytosis, how long after an insult would you expect the platelet count to settle? Let's say I'm on call, I get phoned by a surgical F1 about a patient that's got platelets of 1,000. They've had an acute cholecystectomy. What would your advice be in that situation, Hader? Because they're going to want some sort of follow-up.
In the first instance, I think from my end, I would probably just ask them to wait. Now, how long to wait? I'm not entirely sure, but I would say about a month. Sounds like a reasonable time to follow them up. Maybe follow them up in GP a bit sooner than that.
Yeah, exactly.
But just about a month then.
Yeah, absolutely. So one really key thing whenever you get phoned about a raised platelet count is look at the trend. So you alluded to that earlier, but basically look at the trend in terms of has the patient always had a raised platelet count, or have they recently had a normal platelet count? Because things that make me start thinking maybe it's primary is if they've had a raised platelet count for some time. As if it's just raised acutely and they had a normal platelet count before the operation, for example, or the insult, then that makes you much more likely to think that it's going to be a reactive secondary thrombocytosis. And I would normally say, look, don't worry about it. It looks reactive after their operation. Get another full blood count in about 4 to 6 weeks' time. So 4 to 6 weeks after the insult, to see the platelet count settle. Okay. So that's what you need to do. And just check that the platelet count was normal prior to the insult. There's no evidence for an antiplatelet agent in a reactive thrombocytosis. And so watch and wait is all I will say for them to do. And just normal VT prophylaxis. So nothing special, but doing the normal hospital VT prophylaxis assessment that you would do for low molecular weight heparin, and then giving that as per guidelines. So that would be my advice for a secondary thrombocytosis. Good. So that's one thing that we need to think about. And then you said primary thrombocytosis. So this is where the raised platelet count is due to a primary problem within the bone marrow. That's what we mean by a primary thrombocytosis. And obviously your main thing here you're thinking about is your essential thrombocytosis, but one of your major differentials is polycythemia rubra vera, which I know we have discussed on a previous episode before. But what might make you think that something is polycythemia rubra vera over ET, Ada?
Would it be more linked to the hematocrit?
Yes. Okay.
Yeah. The red blood cell counts.
Fine. So if a patient had a raised platelet count, but also had a raised hematocrit, do you think that's going to be ET or PRV?
More likely to be ET.
Okay. More likely to be ET with a raised.
Sorry. More likely to be PRV.
Yes. Yeah. Exactly. So really important whenever you've got a raised platelet count to look at the hematocrit as well. But what about if you had a normal hematocrit and a raised platelet count? Is there anything else you'd want to look at to make sure that you're not missing a PRV instead of an ET? On the blood tests.
On the blood tests. Trying to think back to the PRV episode. So I can't remember.
That's fine. It's going to be the red blood cell count.
Oh yeah, okay, yeah.
Yeah, and so what I mean by this is the phenomenon of what we call masked PRV, which is where you've got polycythemia rubra vera, but you've developed an iron deficiency, sometimes due to bleeding, but usually an iron deficiency due to such a high production of red cells, causing a deficiency in your iron stores, so that it then limits how many more new red blood cells you can make. You're sort of auto-venesecting, as it were. So instead of needing to venesect these patients to make them iron deficient, to limit their hematocrit, they've kind of done it themselves by running out of sufficient amounts of dietary iron to support the ongoing high red cell production, if that makes sense.
Okay. Yeah,
and so in those situations, those patients with a masked polycythemia rubra vera due to iron deficiency will have a raised platelet count. They may well have a normal hematocrit, though, because of the iron deficiency limiting the number of red blood cells that they can make. But the key clue will be that their red blood cell count will be elevated. So they'll be making more red blood cells, but the hematocrit will be normal because they're limited in terms of the amount of hemoglobin they can make in each of their new red cells due to the iron deficiency.
Right. Yeah.
So they'll have a low MCV, they'll have a low ferritin, but they'll have a raised red blood cell count with a raised platelet count and possibly a normal hematocrit. And that can be really misleading. So that's definitely caught me out before. So that's definitely worth talking about. And then what about, but then you can also say, oh, but you just said that iron deficiency is a cause of a secondary thrombocytosis. So how do you tell the difference between an iron deficiency with polycythemia rubra vera versus just an iron deficiency on its own with a reactive thrombocytosis? Because both of them are going to have low ferritin, low MCV, and a raised platelet count. So how do you tell the difference between an iron deficiency only versus a masked polycythemia rubra vera from iron deficiency?
My head just goes directly to a bone marrow biopsy, but I might just be wrong about that.
Bone marrow biopsy is important, and we'll talk about that later. But it comes back to the red blood cell count on the full blood count, okay? So if you've got iron deficiency only with no polycythemia rubra vera, your red blood cell count's going to be low, okay? Because you're not making very many red blood cells because you're iron deficient, okay? From bleeding, for example, or really bad dietary intake of iron. As with polycythemia rubra vera with iron deficiency, masking the polycythemia, you may have a normal hematocrit, but your red blood cell count will be raised, which reflects that you're still making too many red blood cells. They just don't have enough hemoglobin in them because of the iron deficiency. Yeah?
Okay.
So those are the three different things to just make sure you can distinguish on a full blood count. PRV without iron deficiency, PRV with iron deficiency called masked PRV, ET, which is just platelet count being raised and usually a normal hematocrit, normal red blood cell count, and then iron deficiency only. And the red blood cell count is going to be really helpful. Okay?
Okay, got it. Thank you.
Great. Sorry, we went down a bit of a rabbit hole there. So yes, polycythemia rubra vera is one of the examples of a primary thrombocytosis. We also said ET, which obviously is the topic of today. Other things, myelofibrosis, pre-fibrotic myelofibrosis, which we'll talk about in a bit, and then other myeloid conditions. Any of your other myeloid conditions can potentially cause a primary thrombocytosis. So in particular, MDS with 5q minus, okay, MDS with ring sideroblasts, chronic myeloid leukemia, chronic myelomonocytic leukemia. Those are all examples of other primary thrombocytosis differentials, okay?
Okay, right.
And then finally, I think we just need to remember to always be suspect of blood results that we get in the lab. So don't forget, you can have a spurious thrombocytosis. So for example, burns victims, so patients that have had a lot of burns can get these microspherocytes in the blood, and you can see them on a blood film, and the machine will count those as platelets, but actually they're not platelets.
Just because the size dependence.
Exactly.
Right. Okay.
Other examples are neoplastic cells, cytoplasmic fragments, schistocytes. So in a MAHA, for example, you might count some of your fragments as platelets. Even bacteria sometimes as well can be, if you've got a bad sepsis, they can sometimes be counted as platelets. So remember to also cast the net a bit wider in terms of your differential and consider whether this might be a spurious result.
In a spurious result, would it be worthwhile to just get a film?
Oh yes, definitely.
Okay.
Yeah. Okay, brilliant. So yeah, but I really like the way you broke down that question and said, okay, platelet count of over 700, so that's more than 450. It's been going on a couple of months, so I'm interested. You said you'd look at the trend, and then we consider it in terms of primary and secondary thrombocytosis. So what do you think are the diagnostic criteria for essential thrombocytosis, Hader?
Well, what we discussed just earlier as well about a persistent thrombocytosis
Okay.
that has no other secondary link, essentially, where you've ruled out the other causes of cancers and even the iron deficiency and the other things that we spoke about, and plus or minus doing a genetic test.
Yeah,
Would that be
good.
correct? In the bone
Yeah,
marrow?
yeah, exactly. So the WHO and the BSH slightly disagree on how they define essential thrombocytosis, but the WHO basically has major criteria, which is a raised platelet count of greater than 450, the presence of a driver mutation, in which the three most common mutations are what?
I just remember one, which is JAK2.
Yep, good. Okay, so you've got
Yeah.
JAK2. The other two are CALR, which is calreticulin, and MIPL, which is myeloproliferative. I don't know what the L stands for. I can't remember. But MPL gene. So the presence of one of those three driver mutations are classical. And then thirdly, a bone marrow trophine is what they require by the WHO, with features consistent of essential thrombocytosis, which we'll discuss. And exclusion of other hematological malignancies, so particularly thinking about PRV, CML, and MDS.
Okay.
And then they have a minor criteria, which is exclusion of reactive causes and iron deficiency, or the presence of a clonal marker, which is not one of the three classical mutations. Okay. And you either need all of the four major criteria or major criteria 1 to 3 plus a minor criteria. Okay. And I used to get confused when I was first learning about MPNs. I used to think that if you had a raised white cell count, then automatically, with a raised platelet count, then automatically you're not dealing with ET, you're dealing with PRV. But that's not true. You can very much have a raised white cell count as well as a raised platelet count in somebody with essential thrombocytosis. But the only thing that you would trump it, as it were, is if you had a raised hematocrit. So raised hematocrit will trump your white cells and your platelets and make it PRV rather than ET. Okay.
Okay.
So that's the WHO definition of ET, requires a bone marrow. The BSH definition is very similar. So 1, platelet count of greater than 450. 2, one of the three classical mutations, so JAK2, CALR, or MIPL positive. And 3 is no other myeloid malignancy. But you don't require a bone marrow, so it's a bit more simple. Okay, so any questions about that at all, Hader?
Yeah, just in terms of why the WHO requires a bone marrow as part of the diagnostic criteria and the BSH doesn't.
Yeah, I mean, it's a really good question, and to be honest, I don't know the reason why they disagree. I guess in the UK, we do not tend to really do bone marrows routinely in patients unless that we think have ET, unless we think there is a specific concern in terms of the diagnosis. But we'll often discuss that as an option with patients, and the very anxious ones will sometimes opt to have a bone marrow. The reason, so there are very classical appearances of essential thrombocytosis on the trophine in ET on the bone marrow. Do you know what those classical typical features are?
No, could you explain them to me?
Yeah, of course. The main thing is that in ET, the bone marrow is normocellular, which means there's no proliferation of any of the other cell lines. It's only the megakaryocytes that are proliferating. So even though you may have like a raised white cell count in ET sometimes, you don't see that like trilineage proliferation and hypercellular marrow like you might see in PRV, for example. the other thing is that what you do see is an increased number of megakaryocytes, obviously, because they make the platelets, but they're mostly as single cells or arranged in loose clusters. And the megakaryocytes themselves are quite normal in appearance. So they're large and they have these big staghorn nuclei, which is quite a buzzword. So if you see the word staghorn nuclei, you should be thinking ET rather than PRV, or MDS, because it's just a nice big normal nucleus. And also this thing called emperipelosis, which is where the other cells can be engulfed into the cytoplasm of the megakaryocytes. So basically normal megakaryocytes, a normocellular bone marrow, and an increased number of just megakaryocytes arranged usually in loose clusters. So those are your classical features of ET on a bone marrow. And that's very reassuring, I guess, if you think that someone might have ET and then you do a bone marrow and you demonstrate that they have all the typical features. The reason that you're doing a bone marrow, though, is actually to rule out your other two main differentials, which are polycythemia rubra vera and your prefibrotic MF. So in polycythemia rubra vera, your bone marrow is going to demonstrate hypercellular changes. So it's going to be having lots of myeloid hyperplasia and erythroid hyperplasia as well. And the other thing is that your megakaryocytes are often quite pleomorphic in terms of their morphology, and they're not arranged in clusters. And then, have you heard of this term of prefibrotic MF?
No, it sounds a bit counterintuitive. Some myelofibrosis with other fibrosis. Just myeloma.
Yeah.
So what is it?
Well, it's basically a sort of precursor of myelofibrosis, and it's only really been described recently in the last, I don't know, in the last few decades. And it often presents with just a raised platelet count. So unless you do a bone marrow, you may not pick it up as being anything other than ET. So the patient would have a raised platelet count. You do a JAK2 mutation screen and it comes back positive, and you think you've got JAK2 positive ET, but actually you might have prefibrotic MF, which you wouldn't know unless you do a bone marrow. Okay. You can get some clues as to it being prefibrotic MF instead of ET on the bloods, in that they can sometimes have an anemia, or they can have a raised LDH. And that if you've got a really significantly raised LDH, then that makes you suspect that it's not just ET. And also splenomegaly as well. Genetically, they're the same. ET and prefibrotic MF have the same proportions of the three kind of key driver mutations. And there isn't any change in management between the two, between ET and prefibrotic MF. But the concern is that prefibrotic MF has a much higher rate of transformation into MF than ET would. And so that's why some people argue that a young patient that you think has ET should have a bone marrow as per the WHO to make sure you're not missing a prefibrotic MF. But that risk is still low. So median time to transformation of a prefibrotic MF from diagnosis to myelofibrosis is about 11 years. And a lot of people argue there's no point doing a bone marrow in a young person to see whether they've got ET versus prefibrotic MF, because there's nothing that you can give to reduce the risk of prefibrotic MF turning into MF. So there's nothing that you can do differently. So therefore, all you might be doing is generating a lot of anxiety for a patient and not actually actively changing their management. So it's quite a hot area of debate, and some people are really pro doing bone marrows, and some people are more anti it. I think the key thing is that the risk of thrombosis for prefibrotic MF and ET is the same, and that's the key thing that you need to focus on, is reducing the rates of thrombosis for both of these conditions. And in terms of PRV, I guess it's just useful to know if you've got polycythemia or not, because the rates of thrombosis are different. And also venesection might be an option if you've got somebody with PRV versus somebody with ET where you wouldn't venesect them. So just to summarize that then, in PRV, do you know, let's just summarize what the key findings are in the bone marrow for each of those conditions. So let's start with ET. What's the cellularity of the bone marrow? Is it normal?
It's normal cellular,
Yeah.
normal megakaryocytes, which are arranged in loose clusters.
Yep.
And then we have
And they have a staghorn
and
nucleus.
staghorn nuclei, a staghorn nuclei.
Yeah. Yeah.
I'll try and remember
Perfect.
that.
And
I'll try to
loose
make some Harry Potter
clusters.
connection
Okay.
with that somehow. And then for PRV, you'll have myeloid proliferation and erythroid lineage proliferation as well.
Mm-hmm.
And what am I missing?
The appearance of the megakaryocytes.
They are bulbous?
They're pleomorphic.
Pleomorphic.
Yeah.
Pleomorphic. Yeah.
Yeah.
Okay.
So PRV is increased cellularity, myeloid hyperplasia, and pleomorphic megakaryocytes.
Okay.
And very good. And then what about pre-fibrotic MF?
Pre-fibrotic MF. Again, it's escaping me.
So the cellularity will be increased.
Okay. Yeah.
And there will be also myeloid hyperplasia. And the megakaryocytes themselves, that's the one that have the bulbous and atypical nuclei.
Right, those are the bulbous ones. Okay.
Yeah.
So it's kind
And
of
they
then
are raised
pre-fibrotic is in between PRV and ET on a bone marrow kind of to a degree.
To a degree, but pre-fibrotic MF just sort of mimics the early changes of myelofibrosis. So having
Right, okay.
normal megakaryocytes with the bulbous nuclei and the increased cellularity. And then the other thing to just say is that in pre-fibrotic MF, the megakaryocytes are often arranged in tight clusters rather than the loose ones.
Tight clusters, right.
Yeah.
Okay. All right.
So, okay, so that's a lot that we've talked about bone marrow appearances and why we do a bone marrow biopsy by the WHO and not the BSH. And there is no real right answer, but it's useful to be aware of these issues.
And that's the great thing about hematology is just ever-changing guidelines they have to keep up with.
Yeah.
Which is quite exciting, to be fair.
It is, I agree. So let's go back to other investigations. Obviously, we've talked a lot about bone marrow biopsy, but what other investigations would you do in this patient that came in with the platelet count of 700 and the recent NSTEMI?
I would keep it simple from the get-go.
Yeah.
Not jump to the bone marrow, but start with the history and exam.
Okay, and what exactly are you looking for on the history and exam?
Just in terms of, I would be thinking down that, increased thrombosis route. So history of MIs, strokes, DVTs, PEs.
Yeah.
Petechial symptoms as well, because I'm gonna go down that route of if you have an increased number of certain type of cells, not all of them will be perfectly functioning.
Okay.
So you'll have some platelets that aren't working perfectly as well.
Okay, so I think what you're referring to here is the phenomenon of acquired von Willebrand's disease, that some patients with ET, particularly JAK2 positive ET, can develop an acquired von Willebrand's disease, and that's because of the JAK2 mutated platelets are essentially faulty, and they absorb von Willebrand's factor out of the blood, essentially, essentially making a lower level of von Willebrand factor antigen in the blood, which can lead to a bleeding phenotype. Now, that usually only occurs once their platelet count is over about 1,000. And actually, these are the patients that I worry about the most when doing a bone marrow on a bone marrow list for bleeding, much more than your MDS with platelets of 10. Actually, it's your platelet millionaires, so your patients with platelets of 1,000 and above, that are the ones that are more likely to bleed because of the acquired von Willebrand's disease. Okay, good. So you're going to take a bleeding history and a clotting history. And then also in your history and exam, make sure you're excluding all your secondary causes. So are there any red flags for a solid cancer, for an iron deficiency, for bleeding anywhere, for recent surgery, infection, inflammatory conditions in the background like rheumatoid arthritis, any medications that they're on, etc. So yes, history and exam. Full blood count we've already talked about, and remember we're going to look at the MCV and the red blood cell count, as well as the hematocrit, to interpret all of those indices together so that we don't miss a masked PRV. And then a blood film we talked about in terms of ruling out spurious thrombocytosis, but also looking for things like platelet anicytosis, which is a fancy word for different sized platelets. Often the platelets can be larger and a bit hypogranular, so a bit pale on the blood film in ET. You may have an elevated white cell count of other granulocytes like neutrophils. And you're also looking to make sure there aren't any leukoerythroblastic features or dysplastic features on the blood film, which would actually point you in a direction of a different diagnosis like myelodysplasia, or in the case of dysplastic features, or if it was leukoerythroblastic, you might be thinking more about things like myelofibrosis. And no hyposplenic features as well, so things like Cowell-Jolly bodies, which would make you think that the platelet count being raised is due to somebody having had a splenectomy, for example. So the blood film can actually be really useful for a raised platelet count. And then an LDH is useful because if it's very high, then that makes you think about myelofibrosis and pre-fibrotic MF. Iron studies, very important, in particular the ferritin. A CRP or other inflammatory markers. Bleeding phenotype, we've said already, you do a von Willebrand's factor, antigen and activity. And then molecular testing. So why do you think, what do we test for, Hader? We've kind of already touched on it, but what are the three mutations?
So JAK2, which I associated, as I said before, with Samurai Jack and blood things. CALR. For some reason, I don't know why, it reminds me of Superman.
Okay.
Yeah. And then the last one, which is MPL. MPL.
Yeah, exactly. So those three genes, you can do a 3-gene NGS panel, which include those three. And about 50 to 60% of ET have the JAK2 mutation, in particular that V617F mutation. Then you've got about a third of patients have the CALR mutation, and then about 5 to 10% have the MPL mutation, okay? So those are your three different mutations. So most are JAK2, then a third are CALR, and then a very small percentage are MPL. And those are your three key genes that you need to test for. And you should probably also do a BCR-ABL as part of being able to rule out other malignant causes of your raised platelet count. So a quick BCR-ABL to look for CML, particularly if there are atypical features like basophilia or left shift of the neutrophils or any atypical features on the bone marrow. Okay?
Gotcha.
There are two reasons for doing molecular testing in ET. One is to demonstrate that it's a clonal disorder that's present. But do you know the other reason why I'd be particularly interested to know, not just that the patient has a mutation which allows us to make the diagnosis of ET as a clonal disorder, but there's another reason why knowing which mutation the patient has is useful. Do you know what that is?
Would it be prognosis? It helps you determine their risk and prognosis.
Yeah, do you know about any features of the different mutations and how they tend to predict behavior of the patient?
Not entirely, no.
No. Okay. So basically two things that we worry about are thrombosis. And then I guess, there's actually three things we worry about, but thrombosis is one. And then there's progression to myelofibrosis and progression to AML. And risk of thrombosis, if you have a JAK2 mutation, you're more likely to have a thrombosis compared to if you have a CALR or a MPL mutation. And that's captured quite well with what's called the IPSET thrombosis score. So this is a validated tool to predict arterial and venous events, and it uses the patient's age, cardiovascular risk factors, history of previous thrombosis, and JAK2 status. So if you have a JAK2 mutation specifically, then you do have a higher risk of developing a clot compared to somebody with CALR or MPL. CALR and MPL tend to be in patients that are younger with a much higher platelet count. And so it looks more alarming when you're working them up. You know, they have platelets above 1,000 and you're like, oh, crikey. But actually, they tend to have lower rates of thrombosis. and they actually tend to have more bleeding than thrombosis. So they get more of that instead. And the risk of progression to myelofibrosis is higher with CALR mutation than with JAK2. Okay. And CALR you can then divide into CALR1 and CALR2. So there are two different types of CAL reticulin mutation. And Prof. Teffrey, he says that if you have CALR2 mutation, then you're genetically blessed. That's like his classic line, if you've ever heard him talk or teach. And CALR2, he means that because you have a much lower risk of developing myelofibrosis, and you can have a very high platelet count, but actually have quite an indolent course with quite low risk of VTE. So it's the CALR1 that's associated with the high rate of transformation to myelofibrosis and the slightly higher VTE risk.
Then if you are, for example, negative for all of these and you're still looking down this gene testing route, would it be worthwhile to get other gene testing done?
Yeah, so I mean, you can do a myeloid next generation sequencing panel. Its role at the moment is that it's not routinely done in ET because there's no validated risk tool. So you might get back other mutations, like some of your classic CHIP mutations are quite common in your MPNs. So things like DMNTA or TET2 or ASXL1. But we don't actually understand what they mean for the patient at the moment. The data just isn't there. Sanger have done a personalized risk tool, but it's not evidence proven yet, and it gives an idea of possible effective mutations, which they got from data from the PT1 cohort, which is the big study in ET. And that gives a general idea of transformation risk based on mutations, but certainly it's not anything that's changing management or something that we would recommend doing routinely. But you do have this population of about 15% of all essential thrombocytosis patients who are what we call triple negative. So they do have clonal primary production problem of making too many megakaryocytes and therefore too many platelets, but then JAK2 negative, they're CALR and MIPL negative. And so with those patients, that's the sort of situation where actually doing next generation sequencing myeloid panel might be useful to demonstrate that they do have a primary ET diagnosis. And they're the sort of patients that would also be getting a bone marrow biopsy as well. So that's really the role of it at the moment, but it might progress more in the future. Yeah. Okay. So that's workup of the patient. So we've talked about blood tests, genetic testing, bone marrow testing, and then obviously also think about your other things. So think about things like blood pressure, HbA1c, ECG in this case for this guy, maybe an echo. But we've talked about the basic workup just of the ET part of it. So that's good. So moving on then, I guess the key thing is about prognosis in ET, and actually life expectancy in the first 10 years from diagnosis is not affected. Okay, so we know that in the first 10 years of having ET, it doesn't affect how long you're likely to live. But beyond this, it's a bit less clear. So after 10 years of diagnosis, it's a bit less clear. And basically, all your morbidity and mortality really results from thrombosis, which is the most common issue. But also people can have constitutional symptoms, so they can have night sweats. In particular, fatigue is a big one on quality of life. And then also, obviously, your risk of transformation, both to myelofibrosis and AML. So your clot risk in ET is about 12 per 1,000 patients per year. Okay, so it's quite high. And interestingly, there's no association between platelet count and thrombosis, which I found really strange because when we talk about management in a bit, our target is to get the platelet count down, and yet there's no association between platelet count and rate of thrombosis. And how I've kind of come to terms with this in my head is by thinking that the platelet count is obviously a marker of the disease process as a whole. And therefore, it's not this number of platelets equals this amount of clot, but it's still a useful thing to get the platelet count down because it's a marker of overall disease, which is associated with thrombosis risk being elevated, if that makes sense.
Mm-hmm. Okay.
Arterial thrombosis is far more common than venous thrombosis. So if I had to pick which screening questions I would ask, although I would be asking both of these, I'd be particularly interested in MIs and strokes and TIAs more than I would DVTs and PEs. But they can definitely get both. And in terms of your risk of progression to AML, do I tell people that on the initial diagnosis chat? It's difficult because you probably ought to tell people about it when you're explaining what their condition is, but the risk is about 2 to 5% over about 15 to 20 years. So it's, you know, it's not that common, but the overall survival of secondary AML is about 5 months or something. So if they do transform to AML, it's usually quite bad news. So what do you think are the key management points in essential thrombocytosis, Hader?
So we were speaking about the lifetime thrombosis risk for these patients.
Yeah.
And just looking at the clot burden that they might have, and I would think going down the antiplatelet route, anticoagulation, maybe even, I don't know how much that would serve. And how we said before, reducing the platelet count.
Okay, yeah. So that's one aspect of management. I think before we even get into that, I think something that everybody always forgets, particularly in exams, but actually in real life as well, I think we're not very good at this, is lifestyle modification is absolutely key. Okay, so the only thing that we can modify in the treatment of essential thrombocytosis is their thrombosis risk. Okay, so you correctly identified that is the key thing that we are trying to improve. The key aim of why we even diagnose ET is to try and manage their thrombosis risk, as that's the only modifiable thing. We don't have any disease modifying treatments currently that are effective at like curing people from ET. So lifestyle management is really, really important. And with this is hypertension, cholesterol, diabetes, and smoking, and then exercise and alcohol, all of the sort of primary care things, which we should either be taking on ourselves or making it really clear to the GP how important it is that these are really aggressively managed. So that's the first thing. And then you talked about antiplatelet. So what antiplatelet would you start most patients on?
I would go down the aspirin route.
Okay, what dose?
Yeah. That's a tricky one because just for the ACS thing is all 75 milligrams once a day. Would that still be the case in ET?
Yes, exactly. So in the UK, we give everybody 75 milligrams once a day. But it's a bit of a loaded question because aspirin dosing is done differently around the world for ET, interestingly.
Okay.
And that's essentially because the evidence is not there. There's not been a randomized control trial of different doses of aspirin or different dosing methods. But there's a theory that because they have such a high platelet turnover, some people argue that giving an antiplatelet twice a day rather than once a day is more effective. And so in some places they give BD aspirin, so like 75 milligrams twice a day, for example.
Okay.
And in the UK, if you ask any sort of NPN consultants, a lot of them would say to you that they tend to consider BD aspirin if somebody has a lot of microvascular symptoms, so like migraines, for example, where you think the migraine might be caused by just a bit of a slow flow through the like very small blood vessels in the brain. Then actually a trial of doing BD aspirin is relatively safe and can be effective. So, but for the vast majority of patients, you're just going to do 75 milligrams once a day. Remember that if your patient is what I call a platelet millionaire, so they've got platelets of over 1,000, be very careful about starting them on aspirin. You'd probably want to cyto reduce them first to get the platelet count less than 1,000 and then get them on aspirin. Would you start somebody that you see in clinic like this patient today? I mean, he would already be on aspirin because he's had an NSTEMI, but let's pretend he hasn't had an NSTEMI, but he's got a platelet count of 700 and you think it's primary based on your history and exam and stuff, but you haven't got any of your investigations back. Would you start him on aspirin whilst you wait for the JAK2 and the CALR and MIPL to come back?
No, not immediately, because I can't stratify the risk yet.
Yeah,
From the best of my
exactly.
understanding, yeah.
Exactly. And so you don't want to jump in with aspirin for somebody like him with a platelet count of 700. It's only modestly elevated. And the thing is, he could have, you still don't know yet whether his platelet count is raised because he's got iron deficiency and he's bleeding from somewhere. So you might just make that worse. So generally, only once the diagnosis is confirmed, start them on aspirin, 75 milligrams, and it's very effective at reducing thrombosis as primary prevention. There is also some suggestion that very low risk patients, so young patients less than 40, JAK2 negative patients, patients with no cardiovascular risk factors, probably don't need aspirin. So it's about discussing it with the patient, but most patients will end up going on to aspirin 75 milligrams once a day.
Would you give the gastroprotection with that as well?
Yes, absolutely. Okay. Very good point. Yeah, yeah. Okay. And then the other things are just thinking about anticoagulation then. Touched on that as well. So generally, arterial clots are the more common one than venous clots, and therefore your that's why we rely more on an antiplatelet rather than anticoagulation, because anticoagulation is more to prevent venous events, as antiplatelets are more to prevent arterial events, or that's how I think about it. So that's why we use aspirin. But if they've had a previous clot of any kind, like a DVT or a PE, then those patients should continue anticoagulation lifelong, because they've got a lifelong ongoing risk factor. Even if you control their platelet count, we know that the platelet count doesn't correspond with thrombosis risk. And so in that situation, you would omit the aspirin. So you wouldn't give them an antiplatelet with anticoagulation, okay? So it's very rare to give dual therapy because you don't want to increase their bleeding risk. So it's either aspirin, or if they've had a VTE of some kind or some other reason for anticoagulation, like they've got, I don't know, a metallic heart valve or AF with a high CHA2DS2-VASc, then you're going to leave off the aspirin and keep going with the anticoagulation for life. The most evidence in terms of which anticoagulant is with warfarin, because it's been around the longest, but DOACs seem to be fine. Although there's not really any evidence for that. We tend to use DOACs to anticoagulate them for, DVT in the context of ET. So that's anticoagulation. And then just something else to just consider is things like discouraging the combined oral contraceptive pill use, and taking care with things like HRT, and if they're having ovarian stimulation as part of IVF therapy, to consider thromboprophylaxis in that situation as well.
Okay. What about clopidogrel and ticagrelor and things like that as well? In this patient, they would have started dual antiplatelet therapy anyway, but in other patients that don't have cardiovascular risk factors already.
Yeah, so aspirin's our choice of antiplatelet. Unless if they have a TIA and the stroke team want to start them on clopidogrel, that's fine. Cool. But if we're starting somebody on something and they're not anticoagulated and they're not on any other antiplatelets, then aspirin would be our go-to.
All right.
Aspirin has a safer bleeding profile than clopidogrel, just generally. So that would probably.
And they usually give clopidogrel for a shorter period of time as well, don't they? Like aspirin is usually continued lifelong, from what I understand.
Yes, yeah, that's true.
Okay.
Okay, so that's lifestyle modification, which cannot be forgotten or overstated. And then we've talked about antiplatelets, managing cardiovascular risk factors, and anticoagulation. What's the other big part of ET management?
Cytoreduction.
Exactly. So it kind of mimics the same structure in our head for PRV. And cytoreduction is all about reducing the number of platelets. So we aim for a platelet count of between 400 and 600. Which patients would you consider doing cytoreduction on? If it was a 20, say it was me and I'm 31, and I've got raised platelet count, never had a clot or anything, would you be jumping to cytoreduce me?
No, most likely not. And
why not?
Because your risk factors are significantly lower.
Yeah.
And even giving you a single antiplatelet agent would probably suffice as well, unless you're very high risk. Otherwise, then I wouldn't immediately jump to starting you on something cytoreductive, because it is, at the end of the day, it is a form of chemo, isn't it?
Exactly. It's a form of chemo, so there are theoretical concerns of getting secondary AML. And also there is a definite increased risk of skin cancers, non-melanomatous skin cancers. Also childbearing potential, okay? So you've got to be careful with hydroxycarbamide. And yeah, in terms of my risk factors being lower than the case that we had earlier, both in terms of age, I'm of lower risk factor, but also in terms of the fact that I haven't had any thrombosis, which this man has. So yeah, exactly. So basically, you're going to cytoreduce any patients that are considered high risk by the BSH. So if you're over the age of 60, you automatically are somebody that's going to need cytoreduction. If you have an ET-related thrombosis or hemorrhagic event, then automatically you're going to need cytoreduction. If you've got a platelet count of above 1,500, then again, you're high risk and you're going to need cytoreduction. The other two ones, which are slightly less clear, are if you've got progressive splenomegaly or if you've got symptoms attributable to ET, so like microvascular symptoms like the migraines, or constitutional symptoms as well. So those are the situations in which you would consider cytoreduction. So if we go back to our vignette, the man was 60, so he's not over 60, so he doesn't qualify based on age, but he's just had an NSTEMI, which is likely related to his platelet count. So therefore, he automatically will need to go on to cytoreduction as well as aspirin. Okay?
Okay.
What agents can we use to cytoreduce patients in ET?
My personal favorite is hydroxycarbamide.
Okay.
That's what I remember the most. And interferons.
Yeah, good. Okay, why is hydroxycarbamide your personal favorite? I mean, it seems to be most people's, but why?
It's just, I've just seen it used the most. I think, from what I understand, it is the safest to use to cytoreduce.
Yeah, in a way. I mean, it depends what you mean by safest, but it certainly is around the most, and is easy to dish out, and everyone's quite familiar with it. So yeah, and side effects wise, I would agree. And the biggest trial in ET was the PT1 study, which was published in New England Journal of Medicine in 2005. And this basically looked at hydroxycarbamide use in essential thrombocytosis and showed that cytoreduction using hydroxycarbamide reduced the rate of thrombosis by 6-fold, from 24% down to 3%. Okay. Wow. Yeah. So it's pretty cool. They aimed with the PT1 cohort in this study, they aimed for a platelet count of less than 400. So that's generally what we aim for. But they didn't consider it treatment failure unless it was above 600, the platelet count. So therefore, we've got this range between 400 and 600. And this was also the study that showed that your absolute platelet count doesn't correlate with rates of thrombosis in any sort of linear manner, and that actually the white cell count appeared to be more important, which is interesting. And it seems that if you have a white cell count of above 11, that confers an increased risk of thrombosis and is probably more predictive of your risk of thrombosis than that of your absolute platelet count, which I think is very interesting. So with hydroxycarbamide, they come in a standard 500 milligram tablet. And typically you'll start a patient on 500 milligrams once a day. And you'll counsel them against problems such as mouth ulcers, leg ulcers, thinning of their hair, and in particular non-melanomatous skin cancers. So staying out of the sun, using sun cream and getting regular skin checks. There is this risk theoretically of a leukemia risk, of increased risk of transformation of AML, which the general consensus is that hydroxycarbamide does not increase your risk of transformation to AML. You know, we've been using hydroxycarbamide in sickle cell patients from a very young age, and there's not been any increase of AML there. Although some people argue, well, that's different though, because they don't have an already abnormal malignant clone, if that makes sense. But anyway, and so some people would be a little bit uncomfortable with starting a very young patient on hydroxycarbamide for ET. But most of those patients that are very young wouldn't qualify for cytoreduction anyway. Initially, you do a monthly full blood count, and then 3 to 4 monthly once stable, and then add in aspirin once their platelet count is less than 1,000. And it does seem to improve quality of life to a certain extent. And there's a trial called the Measures trial, which is currently ongoing, which is looking at quality of life and symptoms, like more like constitutional symptoms of ET in patients treated with hydroxycarbamide versus a placebo control.
Okay.
So that's hydroxycarbamide. The other option is, as you said, interferon, which in particular it's pegylated interferon. Which patients would I be considering interferon in over hydroxycarbamide, do you think?
Would it be the high-risk younger patients?
Yeah, exactly. Yeah, exactly. Because of this theoretical concern of secondary cancer with hydroxycarbamide, yeah, I think I would go for interferon in a younger patient. Also, anyone of childbearing potential or someone who's been intolerant of hydroxycarbamide. And I would say that hydroxycarbamide and interferon, pegylated interferon, are like joint first line. So you could go for either of them, and therefore it requires a discussion with the patient about the risks and benefits. I think in general, we're not that great at doing that because like hydroxycarbamide is just so easy to use and people are so familiar with it that it just seems like the easier option. But, interferon is quite cool in that it acts by stimulating your immune system to reduce the clonal burden of the condition. So the actual amount of JAK2 mutated cells goes down. And there was a paper published in ASH in 2017, which showed that you can get what we call a clonal remission in 20% of patients treated with pegylated interferon. What that really means in reality, in terms of meaningful clinical outcomes, a bit like the data we were discussing in polycythemia, rubravir when we did that session, we don't know yet. So some of it might be a bit of spin by the drug companies, but certainly it may be that it's having more of a disease modifying effect than hydroxycarbamide, which we know isn't. It's safe in pregnancy, and the major con of it though is that it takes longer to induce a response, so it's quite a lot slower. And you have to give yourself an injection once a week, and you start at a low dose of weekly subcut 45 micrograms, and then you can increase slowly, and you again do monthly full blood counts, and then once stable 3 to 4 monthly full blood counts. Do you know what the main side effects are that I would counsel people with considering interferon, pegylated interferon in clinic?
Reactions at the site of injection?
Not really, no.
Okay. I'm at a loss, Harry.
That's fine. No, that's fine. And that reflects the fact that people are so much more familiar with hydroxycarbamide than interferon. So some of the really important things that are rare but serious are what I tell them about. So one is sometimes irreversible psychiatric conditions. So people can become psychotic or very depressed.
Okay.
It's very uncommon, but it's a very serious side effect, something I would not take lightly. Autoimmune disorders, particularly thyroid disease. So you check their thyroid beforehand and you monitor it whilst they're on treatment.
Kind of like what, monthly, 3 monthly?
6 monthly, really.
6 monthly, okay.
Yeah. They will commonly get flu-like symptoms, so fevers, chills, bone pains, that kind of thing, which usually settle down. They can get headaches, dizziness. They can get diarrhea and nausea. And then also there is this risk of causing pneumonitis as well. So some things to look out for: you need to monitor their lipids, their glucose and their amylase, as there's an increased risk of pancreatitis, their thyroid function every 6 months. And I would discontinue it permanently if they started getting any depression symptoms. And also optometry annually as well, because you can get, again, this optic neuritis, which isn't particularly well understood, but is a more potentially serious side effect. And if they've got any abnormal liver function or autoimmune hepatitis in the background, I definitely wouldn't be using pegylated interferon. Or if they had a history of psychiatric disease or known thyroid disease, any of those three things, I would say would probably be contraindications to giving pegylated interferon.
And interferon itself is a cytokine as well, right?
Yeah.
So would like a lot of these symptoms as well be just essentially kind of cytokine release?
Yeah, exactly. Well, it's directly from the drug. Yeah.
Okay.
So that would be my first line management. So we've got lifestyle factors, we've got aspirin or anticoagulation, and then we've got all your other cardiovascular risk factors, so blood pressure, glucose, lipids, and then cytoreduction for your high risk patients. Okay, for those over the age of 60, or those who have had a clot or a bleed, and those that have got platelets of over 1,500. And then also a sort of slightly looser area, but progressive splenomegaly or constitutional symptoms that you think are secondary to ET.
The microvascular ones.
Yeah.
Oh, okay, cool.
So what about a second line treatment? Do you know if let's say the patient didn't respond to hydroxycarbamide, what would you do next?
Second line, not sure.
So I would then go to the other option of first line. So interferon.
Oh, okay. All right.
If they had interferon, go to hydroxycarbamide.
Okay, yeah, that makes sense.
Yeah, and then if they didn't respond to either of those, then you can start thinking about other agents like anagrelide. So anagrelide is something that can sometimes even be added to hydroxycarbamide if the platelet control is really difficult. It's an oral tablet. Side effects are minimal, and it can drop your platelet count. But I would say that it carries with it an increased risk of myelofibrosis. So they need a bone marrow biopsy every 3 years, and if there's any signs of that bone fibrosis, then you need to switch to a different agent. And it's contraindicated in patients with heart disease. To be honest, I haven't really seen very many patients on anagrelide. Other options, ruxolitinib has been licensed in the US.
Okay.
But is only available via compassionate access at the moment.
In the UK.
In the UK, yeah.
Right.
So not currently an option. But I think probably will become one in the future.
The beauty of hematology.
Yeah. And then you've got things like busulfan. So just like we used busulfan as a bit of a bomb of chemo for PRV for our sort of older patient.
The Isles of Scilly.
Yeah. Then that's also
listen to PRV to find out more.
Yeah, exactly. But big risk of AML transformation and pneumonitis. So you would only give it to patients with a limited life expectancy due to other reasons. Okay.
Okay.
Great. Okay, so that's kind of management of ET in a nutshell.
And it makes sense as well. Like it's very linear.
Yeah.
Okay.
Yeah. What about another scenario, just quickly before we finish? Something that they love in FRC Path Part 1. So pregnancy. So ET is the commonest myeloproliferative neoplasm in women of childbearing potential. So what would you consider in a woman with essential thrombocytosis who becomes pregnant? And have a sort of framework to think about this. If you're writing an essay, for example, how would you structure it?
If I remember your previous talks, and a good way to classify it is before, during, and after.
Yes.
And also in these, not exactly in childbearing potential, but especially in the during and after, the risk of thrombosis is higher as well.
And you mean before baby, during baby, and after baby?
Yes, exactly.
Yeah.
And so we spoke about peg interferon to be a good choice, especially in the before in high risk patients. I'm not sure if this would still apply in during baby and after baby.
Yeah.
Would it?
Yes, it's safe to use during pregnancy. Interferon can reduce your fertility, so it can actually make it more difficult for you to get pregnant. But preconception, so before the baby arrives, assess risks and sort of optimize therapy. So get her platelet count under good control before you start. And remember that if they're on hydroxycarbamide, you need to stop it, and it's a 3-month washout period. And consider risk factors for complications in pregnancy. So has she had a previous thrombosis or hemorrhage attributed to her essential thrombocytosis? Has she had previous pregnancies, and were there complications? Has she had recurrent miscarriage or intrauterine growth restriction or a stillbirth? And has she had any placental abruption or hemorrhage? And so those are things to consider before conception. And then in terms of during baby and kind of management around the time of conception, every patient should go through an MDT. You should make sure they're on aspirin 75 milligrams once a day, and they should continue on that, because they theoretically have an increased risk of poor blood flow through the placenta. And so for that reason, they should also have a uterine Doppler at 20 weeks to look at the blood flow to the baby. And if it's abnormal, move to a more high risk management scheme. They need to avoid dehydration and anything that's going to increase their VTE risk. And they need to have a proper VTE risk assessment done as per all pregnant ladies in the UK, as per the very good Green Top guidelines. And they're all going to need low molecular weight heparin injections for 6 weeks postpartum as well.
Okay.
If they're high risk patients, so any of the risk factors that we talked about at the beginning, like previous clots or platelet count above 1,500 or previous stillbirth or intrauterine growth restriction, then as I said, interferon can be used. And also consider using low molecular weight heparin prophylaxis earlier on, and regular fetal growth scans to just check that the baby is growing okay. And that's it really. So yeah, I really like that you've remembered that, before, during, and after.
That's all you, Harry.
Well, it just helps so you don't forget what you need to say in essays.
No, completely agree.
Good. Okay. Couple of other things to just quickly touch on. ET in children is super rare. And basically, if you think a child has essential thrombocytosis, then make sure you've definitely excluded any reactive causes, because it's so much more likely to be reactive. And those are the patients that you are going to need to do your myeloid next generation sequencing panel. And in these patients, you aim for a much more conservative approach. Their risk of thrombosis is very low. And you can give aspirin if you've got clear evidence that it is truly a primary essential thrombocytosis. But remember that aspirin can be associated with this thing called Ray's syndrome, where they get liver and brain swelling in children given aspirin.
Yeah.
So it's risk-benefit discussion, really. And make sure you put them on the childhood registry for MPNs. Okay?
Okay, yeah.
Another thing that I think is worth just touching on in this podcast is about the effect that a high platelet count can have on the UNEs. Do you know what it can do to your UNEs?
Yeah, pseudo-hyperkalemia, right?
Yes, yeah, exactly. And do you know why you get a high potassium in patients with a high platelet count?
I would say in the same way that in a burns victim you would have a high potassium as well, because it's increased number of cells, and platelets are just broken up megakaryocytes, right? So would it be because of that? That's my logic with it.
Kind of. It's not the key thing about it is that it's not a true hyperkalemia. So I'm not sure about in the burns victim situation, but if there's rhabdomyolysis, for example, that's not artifactual. That's
right, yeah,
a true high potassium. But the high potassium in somebody with thrombocytosis is artifactual, because the time when the potassium leaks out is from the platelets when they're sat in the tube.
Okay.
So that's why you can get a more accurate potassium in somebody with a high platelet count if you get a rapid turnaround of that sample. So nice fresh sample, take it straight to the lab, hand delivered, or you can use the lithium heparin Green Top, or do a VBG, and that will give you your true potassium within the patient, rather than it leaking out because there's so many platelets in the blood in the tube.
Got it.
Sitting there.
Got it. All right.
Okay, fantastic. I think that's really it. I don't think there's much more to say about essential thrombocytosis. So maybe this would be a good time to just go through sort of the main 3 key take-home points.
Sounds perfect.
So I would say the first point is that a raised platelet count is far more likely to be secondary than it is to be primary. So if you think somebody might have ET, make sure you've done your homework to rule out your secondary causes, particularly in your history and examination. Think about cancer, think about iron deficiency with a ferritin, think about inflammation with a CRP. And look at a trend. I always look at a trend when I get phoned about a raised platelet count, because if the patient has recently had a very normal platelet count and then had an insult, then that is a reactive platelet count and you really don't need to worry. But if somebody, when you look back, you can't actually find a normal platelet count and it's always been a bit on the high side and slowly going up, then that's somebody that you might want to send off a JAK2, CALR and MIPL screen.
Mm-hmm.
The second thing is that in terms of the genetics of ET, 50 to 60% of patients will have the V617F JAK2 mutation. 30% will have the CALR mutation. 5 to 10% will have the MIPL mutation. And 15% will be triple negative. Okay, and they're more difficult to diagnose. And certainly be considering a bone marrow and possibly a myeloid next generation sequencing panel. And thirdly is that the only thing we can really do about essential thrombocytosis is reduce the risk of that patient having thrombosis. And that's why we want to diagnose it. And we can do that through aspirin, lifestyle modification, anticoagulation if they have another reason for anticoagulation, and in which case it needs to be lifelong. Cardiovascular risk factor management like lipids, cholesterol, blood pressure, diabetes, smoking and alcohol, and then cytoreduction for your high-risk patients.
Perfect. Thank you so much, Harry. That was
great.
That was very linear. Loved it.
No worries.
And I'm excited for the next one.
Yeah, me too. Great. See you later, Hader. Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.